Okay, started.
Next page, ma'am.
Total 6 rooms, okay?
Next, ma'am.
Just wait.
Next, ma'am. Next, ma'am.
Started your 10 minutes time.
So, hi, I'm Muthulakshmi, one of the candidates for MRC Part 3 exam. I read the instructions ready for the structured discussion.
Okay. So shall I
Okay.
shoot?
Yes, ma'am. So here I have 6 reports for interpretation. So the first report. So with the acute parvovirus infection, 36-year-old with 26 weeks pregnancy with reduced fetal movements, it's not feeling unwell for a week, and scan also showed a echogenic bowel in the fetus. So coming to this implication, so acute parvovirus infection for a mother, we need only supportive treatment. For the baby is at risk of anemia, fetal anemia, hydrops fetalis, and sudden intrauterine death. So here, uh, the patient needs to be called and informed about the reports, and she has to be sent for to fetal medicine opinion for 4 to 5 weeks after acute infection for serial growth scan with middle cerebral artery peak systolic velocity monitoring to identify fetal anemia. So apart from this, we also need to check since she had an echogenic bowel, other causes of echogenic bowel, whether it was in Down syndrome screening is normal, and whether any history of cystic fibrosis and cytomegalovirus. So all these things needs to be checked, and serial growth scans will be offered to her.
Okay. Anything else, or shall I move to the next room?
Next,
You can say next, okay? Whenever you are
okay,
done.
next. So this one, with endocervical swab positive for chlamydia trachomatis, it's a teenage pregnancy with 10 weeks for termination. So before offering a termination, we need to treat this infection. So implications in a short term, peritonitis and pelvic abscess and pelvic inflammatory disease, and long term she'll have a sequelae chronic pelvic pain, ectopic pregnancy, and infertility, and she will be treated now with an azithromycin, and she'll be referred to the gum clinic for further follow up of swabs, partner testing, and reports, and she needs for other tests for sexually shared infections, and also she will be offered an safe sex practices. And after treating this infection, and she will be proceeded for termination as per the protocol. Same will be communicated to the patient.
Okay.
Next, so room number 3. So an IUGR with an oligohydramnios. So primigravida, 38 weeks of gestation. So here the implications will be a sudden intrauterine demise of the baby. So here we'll be calling the patient, explaining the reports, and we need a further test like Doppler indices of an umbilical artery and middle cerebral artery, and also CTG and vaginal examination for the Bishop score. And she will be offered a here. We need to know the presentation and also placental position. So she'll be offered an induction of labor, and after explaining pros and cons to avoid sudden intrauterine demise and to follow labor care protocols in labor.
Okay. Anything else?
She'll be offered a continuous CTG monitoring and one-to-one care. Labor care guide will be followed during labor.
Okay.
And, 4. So, anteropositive in a 40-year-old primigravida and 36 weeks of gestation. So, here this anteropositive implications on the baby will be congenital heart block and neonatal cutaneous lupus syndrome. And this case will be discussed at the MDT team. And here are since it's 36 weeks of gestation, so fetal echo is not possible. If done earlier, we'll review that. And any rhythm abnormality for the baby in the heart rate will be checked by the fetal medicine expert for a detailed scan will be offered to her. And further, and she's a high risk pregnancy with anteropositive, so she'll be decided in the MDT team for the when to time of delivery and also mode of delivery. And apart from this anteropositive, so since it's a 40-year-old, so prolonging the pregnancy beyond 38 weeks has got the complications of sudden intrauterine demise, so which will be explained to the patient and accordingly it will be decided. Next. So this is an abnormal oral glucose tolerance test. So the primigravida, 28 weeks of gestation with the BMI of 35 kg per meter squared and with the family history of diabetes. So here she'll be, the results will be communicated to the patient and she'll be offered to join diabetic and antenatal care to offer an dietary advice and to start an oral hypoglycemic agents or insulin with the help of endocrinologist and serial monitoring of sugars will be done and serial growth scans will be done to monitor the growth of the baby. And implications for the mother is uncontrolled sugar with the recurrent urinary tract infection, vaginal infections, polyhydramnias, increased risk of preeclampsia, and for the baby, unexplained intrauterine demise and the macrosomia. And she'll be followed up in a consultant-led care unit with the MGT team. So this sort of next one. Down's risk is high, 1:150 in a 36-year-old. The quadruple screening stage at 16 weeks of gestation. So here the risk will be, so this confirmed Down syndrome, in serious cases, it has got structural anomalies and with mental retardation and sometimes the baby might not survive. So here the patient will be called and results will be communicated and she'll be referred to a fetal medicine experts. This has to be confirmed by a definitive testing like now at amniocentesis. And she will be explained about pros and cons of amniocentesis and NIPT, and amniocentesis will be a definitive test. And considering her age also, it's increased risk of genetic defects. And she'll be explained about the procedure, about 1 in 200 risk of abortion this procedure carries, and her wishes will be respected. That's it.
That's it. Last 2 minutes.
I'm not remembering anything. We can discuss, ma'am. Go for discussion.
Okay. Very well done. Anybody wants to comment on this? No, nobody is interested to comment. Very well done. See, how one need to go in such task is organize yourself because you are having a sufficient knowledge to uh, offer the type of management regarding that cases. Only thing it is in a short time you have to tell those management. So gather whatever knowledge you are having, gather whatever information you are having. So what is the situation? Firstly, you just identify the situation in each task, then whether there is any background is there, if they had mentioned any background, if it is so, please ensure you will name that background and tell the anticipated risk and complications or implication what she has used the word. So you can say anticipated risk in these cases and the complication associated with this condition, and then come up with your recommendation, assessment and recommendation. So what you would like to assess and what will be your recommendation. So something like, okay, so here I would like to refer her to the fetal medicine expert who will be deciding regarding the confirmatory or non-confirmatory test, explaining the pros and cons of the procedure. Now assessment has been done. Now recommendation, depending upon the report, we will discuss the further care. Whether the patient, if the reports are positive, whether the patient wants to continue, refer her to antenatal care. If negate, if doesn't want to continue, then refer her to the termination services. So this is your recommendation for that particular case. So it is very simple, easy. One can do it very easily. Okay. So the first task. Okay, the first task actually you had identified that it is a parvovirus infection. You mentioned decreased fetal movement, echogenic bowel. You rule out echogenic bowel. Echogenic bowel. It was echogenic bowel or echogenic heart. Echogenic
Ma'am.
bowel. Yeah, echogenic bowel. So you rule out whether there are any congenital means previous double marker test, previous anomaly report. So everything you had ruled out, you wanted to know. So you had sent her CMV, cystic fibrosis, serial growth scan. So those points I had not mentioned in my answer key, but you can very easily say all the points which has not been mentioned. Okay. So situation and background here is reduced fetal movement in case of parvovirus infection, which is acute parvovirus infection. You can mention see, huh? Because IgG and IgM M is also positive. So it will be an acute parvoviral infection at 26 weeks in primary gravida. So that is situation and background. So anticipated risk, maternal risk is nothing. It's just an infection which she will recover. But the serious fetal risk will be anemia, hydrops, intrauterine death. That is another issue what we can have. So now assessment and recommendation. MDT, obstetric consultant, referral to the fetal medicine unit for MCA PSV Doppler post infection. If normal, then serial follow up. This you had missed, Dr. Muthulakshmi, that if MCA PSV is more than 1.5 MOM or more than 90th percentile for that gestational age, the intrauterine blood transfusion will be offered to this case. Yes or no? Okay. So the transfusion of compatible fresh collected double packed RBC with a hematocrit of 80%. Most of the time it is O negative, KL negative blood will be offered to these patients, eradicated and CMV negative. So this needs to be offered in utero by fetal medicine expert. Once done, then there will be a serial monitoring of the scan. MDT for decision to deliver depends upon the recovery from anemia, since it is not RH isoimmunization. In RH isoimmunization, the ongoing insult is means continued, so you have to deliver the baby early. In this case, if the acute event has completed and the baby has recovered normally, then there is a very good prognosis of the baby. So you just need to follow these babies with serial MCA PSV at fetal medicine unit. And recovered from anemia, just wait and watch, no other intervention needed. If early delivery needs to be considered, offer her steroids and ICU backup, neonatologist offer PIL. Okay, so these 2 3 points you had missed out. Everything was done very nicely. teenage top with sexually transmitted infection, okay, with chlamydia trichomatosis. So it, if untreated, yes, untreated, she has mentioned that short term implication and long term implications. So short term, it might be a PID infection, endometritis, if it is surgical termination, if we are going to go for, okay, long PID also, TOPSIS, and in long term it will be ectopic, subfertility, chronic pelvic pain. So treat with azithromycin, screen for other STI, refer to GUM for contact tracing, counseling about sexual intercourse during treatment, rule out sexual abuse if so involved safeguarding, because she's teenage, okay, because she's teenage. Safe sex, and once treated, top according to the protocol. Whether she will go for surgical or medical line of treatment, we need to decide. Then late onset asymmetrical IUGR or fetal growth restriction with normal Doppler. So SGA rather than FGR, I will say here SGA. No, normal Doppler. No, the Doppler is not mentioned. AFI is also less. So it is actually SGA and oligohydramnios. Huh? So SGA plus oligo at term. So increased risk of, now here the implication of this, yes, there is chances of increased risk of adverse outcome in fetus and neonatal, uh, hypoxia, distress, and ICU admission, sudden intrauterine fetal death. So all these are the implication of this case. So Doppler assessment from fetal maternal unit for umbilical artery, middle cerebral, and ductus venosus waveform. If SGA with normal flow, offer induction of labor at consultant led care unit. Neonatologist will be there. This you had not mentioned here, with a backup, an ICU backup. Okay, because you yourself mentioned that there is a risk of adverse outcome in spite of intervening early. Continuous fetal heart rate monitoring throughout the labor, cervical assessment for induction of labor. Any abnormal changes or Doppler flows like a reversal or absent in the umbilical flow, cesarean section is recommended. Yes or no? Yes.
Yes, ma'am.
With steroid coverage if it is planned. Hmm? Then stillbirth, sorry, not stillbirth, SNB, that is S bar. Elderly, near term, anti-Ro positive. Okay, so rightly mentioned, the baby is at risk of congenital conduction defects or heart blocks and intrauterine death because of anti-Ro antibodies positive. And the mother is at risk of thromboembolism or thromboembolic complications. Even abruptions and IUDs are very common, miscarriages are very common. So she will go for a multidisciplinary team management, including consultant and hematologist. Continuous heart rate fetal monitoring throughout her labor, assess risk of thromboembolism. According to the risk, low molecular weight heparin will be offered to us. This was missed by you. Accordingly, discuss early intervention, early delivery. Mode of delivery will be discussed in MDT. Induction at 38 or 39, whatever you justify, because she's elderly also, anti-Ro positive also. If Doppler indices are normal, 38 to 39 weeks, you can consider induction of labor. She will be referred to the fetal medicine expert for Doppler. And babies, although it is not possible to review her 2D echo at this point, but heart defect or heart block can be identified at this gestation. So this will be offered from fetal medicine expert unit. GDM at risk of macrosomia, shoulder dystocia, stillbirth, polyhydramnios. Assessment and recommendation here will be, it will be MDT, that will be joint care involving the dietitian, diabetic clinic, initiation of treatment, that is metformin or insulin depending upon her sugar, serial blood glucose monitoring, serial fetal growth measurements on USG, discuss mode of delivery, neonatologist available. See, you are missing out on this part, Muthulakshmi, repeatedly, that NICU,
Yes, ma'am.
neonatologist.
Intrapartum. Yeah.
Yeah, you are missing out on a postpartum. Once the baby will be delivered, your neonatologist will be there and NICU will be available. Okay, and continuous fetal heart rate monitoring throughout the labor. High aneuploidy screening, increased risk of trisomy 21 and other aneuploidies in the fetus. Counsel for, yes, you are going to inform the patient in a sensitive manner regarding the reports. Discuss the options with her, that is invasive and non-invasive. Discuss positive, discuss negative of both the options. The option here will be, she's 16 weeks now, so option here will be amniocentesis. The risk of miscarriage we need to discuss, that is 1 in 200. Risk of NIPT, and also the NIPT, that it is not an confirmatory test, but there is very good sensitivity to diagnose the condition. So both the options can be discussed to the patient. Here, refer to the fetal medicine expert unit for further intervention. A detailed anomaly scan from fetal medicine unit. Depending upon the result, we can discuss either to end or to continue pregnancy. So, if whatever patients of, we will respect her repeats, respect her wishes, and further continuation of care or in termination will be discussed and offered the further follow up. Okay, so that is what all this is about. So this is very nicely done by Dr. Muthulakshmi. We will not waste timing discussing the domain wise scoring, because it is nothing in that. This is what exactly we need to go. We will discuss in both the task in common, one task only.
I have one doubt.